If you look at their tables in that paper, there are some effect sizes that are actually negative, which means that the people in the treatment group change less than the people in the control group. You do get some studies where the effect size is 0, which means that they change about the same, so that no treatment and treatment had similar results. And there was one that's a real outlier that was like over 3, which was actually a highly structured kind of life disease therapy. So I think one of the reasons I use this slide when talking about effectiveness with older adults is I think it's an interesting question. I think we've definitely shown that psychological interventions and medications work with older adults for depression. Whether it could be improved further, I think, is an interesting question in light of the younger adult range that we may not be doing as much or adapting it as much as we could. Most of what's been studied, with very few exceptions so far, has been taking the same stuff that we've always done with younger adults and doing it with older adults. Sometimes with kind of minimal adaptations, like if you use handouts, making the font on the handouts larger, or a little more repetition or something like that, using any big changes in the intervention itself. It's just not atypical of what we do in general. A lot of medical interventions as well as psychological interventions are sort of developed on young people and then sort of applied to older adults without a lot of change or thinking about it. Over the last we've had a few rounds of evidence-based treatment stuff coming out from like the late 90s up until very recently, and different groups within the Psychology Association have been refining the criteria for what counts as evidence-based practice. They have pretty much taken as their model medication criteria. So the same kind of rules the FDA uses for judging medication. And there's actually like 3 different methods implicit in these first couple of slides of thinking about what's been shown to be effective. In the initial tests themselves, you're typically looking for a statistically significant effect, of course. You're going to be concerned about the effect size of that effect, so that, if it's statistically significant but really small, you're probably not going to be, well, you might be super impressed because you did it, but other people won't be super impressed with the results. There's increasing focus on tracking things like the percentage of people that are no longer diagnosable with the targeted psychological problem, and some other metrics of clinical significance, aside from effect sizes themselves. It's getting to be really typical of the effectiveness literature in general, although sort of just coming into effectiveness studies for older adults, that we also want the comparison group to be a psychologically plausible placebo intervention at least, rather than comparing people to no treatment. Particularly for depression, people feel like the ship has sailed on the idea that psychological interventions are better than doing nothing. And the question becomes, to what extent are psychological interventions and medications better than appearing to do something but not doing anything that you really think is going to work? It's like the equivalent of placebo medications. So, I mean, if you're on a waiting list or you're just not doing anything while treatment is going on, you know that nothing's happening, and also So pretty clear that particularly in older adults, you don't get a lot of spontaneous remission of depression. Younger adults, you get some, but not as much change as you get in any kind of active therapy. So there's getting to be more and more of a push for comparison of either a plausible psychological placebo or a treatment that's known to be effective, so that you then show that your new treatment can tie with an old treatment that's been shown to be effective so often that there's no doubt that it's effective is another way to go. Which is, again, similar to what you can do in medication studies. If there's an existing medication that's been shown to work, one of the procedures for testing a new one is to show that it's at least as good as the old one. Usually has to be either better clinically or as good as, but with fewer side effects, or kinds of, or just different, so that we can keep a patent on it and continue to charge more money for it.
In the reading, it's generalized as psychosocial interventions. Are all of these considered psychosocial, or are there?
There's no hard and fast line between psychological and psychosocial. It tends to be some combination of probably the discipline and the writing style of the writer. I tend to be broader in the language I use than some of my colleagues would do, because I've spent about as much time training social workers and gerontologists as I have training psychologists. If you're more chauvinistic psychologist, you'd always say psychological. So one is just like the original studies themselves. The second one would be combining the individual studies and meta-analysis, which is what we were looking at in the previous slide. And then when you're doing when you're doing meta-analysis, there's a lot of good reasons for doing meta-analyses over just like kind of qualitative reviews and counting heads for, like, how many studies said you got an effect and how many studies didn't. But one of the things that does happen when you're doing a meta-analysis is that studies, particularly studies with kind of smaller samples that have good effect sizes but that were not statistically significant, count, which some people have problems with. On the other hand, one advantage is that if you're doing it right and you're really including all the studies, then null results and negative results also count against you. When you're using evidence-based principles, every time I do this, I said, I'm going to get rid of that, and I forget.
It's okay, it keeps us honored.
I've been having a discussion with myself for years. The evidence-based rules that are being applied in these reviews and that are being applied in all of the evidence-based practice kind of things count favorable studies and do not count against you unfavorable studies, which is also the way that medications get approved. You have to have like a certain number of significant studies that meet certain criteria in order for medicine to be approved, but you don't get dinged for all the studies that you did where it didn't work. So, and I've never actually gone back to look at the original references on this, but I've heard in several conversations with scientists who this kind of work that, like, when they approved Prozac, that there were like 20 or so studies showing that Prozac didn't do anything before they got the 2 or 3 that got to the approval, so that became one of the most popular medications around. And so I'll make comments a couple of places on these, but these have some of those issues as well. So one of the things that was actually a surprise, one of the first of these kind of reviews that was done